All right, hi everyone. Thank you for joining the APAC community call today. Today we have, let me shift to the agenda. Yeah, so today we have some Odyssey news to share about the updates on the APAC symposium that's coming up this November. After that, we'll formally introduce the new APAC regional chapter, India, and Swetha is here to do this for us today. I hope I pronounced your name correctly, Swetha. And followed by that, we'll have a short update to play a recording on the clinical registry efforts in Odyssey. This was actually, I'm glad Nicole is here today. I think she was the one who suggested this. So yeah, let me just move on to the updates. So, guys, Taiwan has announced that it's going to lift all quarantine restrictions beginning October 13th. I see Mu is very excited about this. She's dancing right now. Yeah, so following this decision, the steering committee of the Odyssey APAC community, we decided that we will move forward with hosting the event in person and in virtual as we originally planned. So all the registration pages have been updated to reflect this change. If you've been waiting for the in-person event until now is your time to register. Let me just show you how the pages are set up so that so this is the registration page for the tutorial workshop. The tutorials, there's no, it's not differentiating virtual and in person because we're not charging any different. So not a big change on the tutorial workshop registration page, but for the main conference, if you click on the tickets, there are options that are both virtual. So it will have the tag in front of the ticket name. So while it's loading up, there you go. So for local registrants, as we've already announced last community call, we're exempting fees for local registrants in Taiwan. For international registrants, you get the option of registering a virtual version of the event or the in-person version of the event. The pricings are a little bit different, so depending on your availability to participate in the event in person or virtually, please buy the right ticket. So yeah, that's the update for the symposium. Yeah, Mui.
I would encourage everybody on this call to come join us in person because it's been a long time, right? That's why I'm jumping up and down to say, yay, it's finally open. We formed this APAC community actually at the beginning of COVID. We formed it and we wanted to do an in-person one all the time. And then suddenly COVID hit, right? So honestly, this is the first time all of APAC Odyssey is going to get together in person, which is a great event and a historical event almost, right, in Taiwan. So I encourage those that can come. Most of you guys, I know those in Singapore and Australia, it's a little bit further, but for most of us, it's well, not me, but for the rest of you guys, it's a few hours. So come on by, right? Join us. We got lots of activities. We got folks from Global. We got folks from Taiwan there, as well as you guys will be there. We're going to have a good and fun time. So we encourage you guys to register. I sound like a salesperson, but okay, never mind. Keep going.
I think you are a salesperson, right? On your original job. Yeah, so guys, yeah, as Mui said, please register. We'll hope to see you there. I think I'll be there myself as well. I don't think Mui's giving me an option. She's nodding for me. Yeah. So another update, one last update is that the poster submissions have passed. The deadline has passed. We have several submissions. We will review individually and let you know whether you have passed or I'm pretty sure everybody passed. But yeah, we'll let you know separately through email. And last of all, if there's any further updates, we will be posting this on the APAC Symposium website at odyssey.org. So please stay tuned on this website. Check in regularly in case there are any updates. I will be sharing updates as they come through either email or through community calls like today. So yeah, that's all for me. I would like to now pass on to Swetha to formally officially introduce the India chapter. So Swetha, would you like to share your screen, or would you like me to keep doing the clicking for you today?
Could you please share the screen for me?
Sure, no problem.
Thank you.
How come? Do you guys see the bar in below? I don't know. Okay.
No.
Okay, good. It's only for me. There you go, Swetha, please.
Okay, I'm not able to see the screen. I don't know. Okay, better I'll share my screen. I don't know. I'm
No,
not able to see the
hi,
screen.
Shweta. We are able to see the screen, Shweta.
No, I think I have an issue. I'm joining from OHDSI Teams, so I think I have an issue. Yeah.
Okay.
Okay, I'll stop sharing.
Yeah, please.
This is also just as exciting. New chapter.
Yeah, it is actually.
Right?
The 7th
Yeah.
chapter. Yeah.
I know. It'd be lovely to get more too. Maybe we should set a goal, 1 chapter a year.
Is that realistic, Movie?
There's a lot of Asian Pacific countries, right? Right,
Yeah.
Mark? There's quite a few of them out there. We got Thailand, we got Vietnam, we got Austria, we got Malaysia. I'm just naming a bunch, just off the top of my head. So 1 a year, I don't know, might not be as not realistic, potentially doable, you know?
Hopefully somebody's gonna take the lead on that, right?
Well, we want the community to help us take the lead. So if you guys got friends out there, in these different countries, tell them about Odyssey, tell them about what we do, right? And maybe folks will get interested. I mean, Thailand's pretty darn interested, and they actually have a conversion going on. So I wouldn't be surprised, if they come on board soon. We can see your screen now.
Yep.
Yes. Am I audible now?
Now I can see myself.
Yeah,
there we go.
yeah. Yes.
There we go. Perfect.
Yeah. So first of all, we are very happy to announce India chapter on this platform, and thank you so much for giving me this opportunity. I'm Dr. Swetha, works in GVW, the Global Value Web, as a real world data lead, and also works for OHDSI India chapter. We started our R&D on RWE or OHDSI in the year of 2020 and realized that India has a lot of potential in conducting the real world evidence studies, and but we noticed the importance of having a chapter specific to India to address the challenges, like we have a lot of challenges that are specific to our Indian healthcare system. So we got a very good response from the collaborators when we started talking about this plan, and we strongly believe that we will make it big. So coming to the agenda, OHDSI India chapter, I'll show our aims and objectives of this initiative, and the interim board member plan that we have now, and the therapeutic areas of interest that our collaborators showed to generate the studies or the evidence, and the action plan that we are doing, the real world evidence platform, which is powered by OHDSI, and the ongoing work as of now. So coming to the aims and objective, we wanted to promote open science to generate new avenues in India, which will help the population mainly in the low economic strata, rural areas, and most prevalent communicable and non-communicable diseases in India. And we want to establish consistent methodologies and best practices for data protection and expand awareness of real-world data and real-world evidence studies in India, and expand access to patient data in India, standardize them to OMAP standards, and conduct observational studies across multiple real-world OMAP data sets. And to perform secondary research using OHDSI tools that addresses the healthcare needs in India. So these are our aims and objectives in specific of this initiative. So coming to next, our board member plan. We are yet to become strong, and this is just an interim board member plan, and we will come up soon with a strong team. So our president is Pathiban Sulur, and our vice president is Dr. Vikram, and we have to yet to nominate secretary, and our treasurer is Ananda Ramchandra, and our chapter leaders will be Lakshmi and myself, Swetha, and the committee members Giridhar, Shyamali, Krishna, Dr. Kansa, Dr. Nidhi, and Dr. Suhan. So this is our board member plan. And coming to when we started speaking about this to various people, various collaborators, the doctors, hospitals, and the pharma companies in India, we realized these are the specific therapeutic areas of interest they showed as of now. But these are not specific. But as of now, we started working to get data partners, or to work to prepare the protocols in these direction. The first one is the infectious diseases, that is the MDR, TB, multi-drug resistant tuberculosis, the leprosy, and the dengue, and the neurological disorders coming to Parkinson's disease and Alzheimer's, and the oncology like breast cancer and HPV, human papilloma virus, and the genetical disorders like thalassemia. These are the few therapeutic areas of interest that our collaborators showed as of now. So coming to next, what is the action plan and what is the challenge, actual challenge? The challenge is the observational studies and evidence-based healthcare always remain unmet needs in India. And after COVID, really, we as India realized a lot, like these studies are very important, because we saw the other like areas doing these studies, because our poor healthcare systems and the data standards, even few people are still maintaining the paper-based things. We found out some challenges over there. So our aim is mainly to build a regional federated OMAP data network, leveraging the open ODC data tool suite, and to establish evidence-based decision making for management of diseases which are of national or maybe for the global interest through the secondary research. So the a result, what we want to get out of it is a sustainable infrastructure and public health, and mainly to generate real world evidence case studies, so that we can show it, hey, this is what we can do in this process. So we want the case studies to get more and more people into it, and preparing for the future from pandemics or health emergencies, mainly like COVID-19, and support clinicians with different and optimal treatment decisions, and upskill healthcare community to support data standardization mainly in India. So this is our action plan, and to develop the real world evidence platform which will be powered by ODC. So the ongoing work as of now, we started building the real world evidence platform, and then finding out data partners and collaborators, which will be a bit challenging in India, and preparing proposals for therapeutic areas of interest. We started with MDR TP as of now, and we started creating work groups, and started a study feasibility of mapping Indian hospital information system data to OMAP common data model. The data partners are JSS AHER. Like I can come up with more updates and more updates on the work groups and what we are doing maybe in the next call. That's like maybe in few months, I can say. So this is all about what we are doing. Thank you for giving me this opportunity again. I'll share you the brochure in the chat. Maybe you can help us sharing with your colleagues, and just to make it big, we really need your support as well. Yeah, that's all.
Awesome. Can I ask a question for those who might want to join or are interested in your chapter? Are you guys set up in the OHDSI environment already? Do you guys have an OHDSI teams for India?
Yes, we have a teams formed already, Mui. Yeah, we have.
And how often do you guys meet?
Not yet started. Maybe
Okay.
when actually we want to do it once the symposium is done, because most of the people are going there, and we also have few festival time this week, so most of our colleagues are not available. So we thought once everything is done and this symposium meeting is done, we will start doing it. Yeah.
Oh, looking forward. We invite you guys to Taiwan as well to join the APAC one too.
Sure, Moi. Yeah, we'll try our best. Yeah, sure. Thank
Oh,
you.
Moody,
Thank
you
you.
totally beat me on that. I was going to chime in and say, come to the APAC meeting in Taipei.
You know,
Yeah.
I also have a question, Swetha. So the therapeutic areas,
Yeah.
I'm just curious, like how were they chosen? Are they more prevalent in India, or like is there a specific reason, or maybe the specific group you are currently working with are more specialized in those areas? I'm just wondering.
It's more
Yeah.
specific to India. Most of them are more specific to India, and we are struggling. We have observed a few reports that are prepared on the national wide, and a few studies which they have done. So we thought we chose it depending upon our collaborators' interest too. So it's not specific to that, but as of now, our collaborators shown interest in that area.
Yeah, I think that's a great approach, right? The
Yeah,
need for research, the interest for research also helps
exactly. Yeah.
the spread of Odyssey. And if that interest aligns with everybody in India, in terms of a very India-specific diseases, I think that's probably going to help your initiative. So yeah, I think that's a
Yeah.
great approach. My other
Yeah.
question I had is, so I know as a Korean citizen that Korea is a very highly IT developed country, but I also know India is a very IT developed country, but I'm not sure in terms of EHR implementation, how, like, since Odyssey, the OMAP requires a database, right? I'm just wondering how much of the data in India, the hospital data in India are currently available in electronic format, right? If you just mentioned a lot of hospitals are still using paper formats. So
Yes.
do you know, I'm just asking for a very high level figure, like do you know how much approximately how much of the hospitals in India are currently using EHR systems?
Yeah, I can say that most of them started moving towards electronic because we have a digitalization thing in India started, and like our thing, right? They wanted to move the complete paper base to digital in 2025. By 2025, our government wants to move the complete healthcare system, and they have started a program as well. Like even the government sector hospitals are trying to move it to digital format. So it's a,
Okay.
it's like at this moment Odyssey India chapter is a great moment because everyone is trying to move to digitalization, and they are started thinking about standardization and doing the secondary research as well, because they understood the importance of it when we saw fighting for this COVID, right? So it's a right moment. By 2025, our government wants the complete healthcare sector to be moved to digital based. So they
Oh,
want to
yeah.
stop this paper based. Yeah.
Okay, this is great news, right? If you have government support on this, I think this will also help the Odyssey initiative that you're currently pursuing. My last follow-up question, sorry to ask so many questions,
Yeah,
but my
no
follow-up
problem.
question would be
Yeah.
that, is there any government funding of coming from this initiative, the 2025 initiative, or is it just a so typically, if a government wants something, they do release some funding so that organizations can actually spend some of that funding and actually help accomplish that target that the government has set up. So do you know if there's any funding provided by your government? Because in the end, it's all about money, right? Like you're gonna need to have people who are going to do the ETL, whether it's hospitals doing it themselves or if there are any subject matter experts who are helping out with the ETL conversions and everything, right? So yeah, my question in short, is there any funding coming out of the government, or is it for now it's still a question mark?
Yeah, it's a question mark for me
Okay.
too. It's a bit early to answer to this question. Maybe yeah, we are also working in the task in that perspective actually.
Okay.
Like maybe in upcoming calls I can give you some information for that as well. Yeah.
Yeah, thanks. You know, I wasn't asking because I was asking like looking for a definite answer right now, right? Like
Yeah,
I
yeah,
do
yeah.
understand things are can be indefinite at the moment. So yeah, thanks for your feedback. It's really
Yeah.
interesting to see another country coming on board. By the way, I did live during my childhood, 5 years in India.
Oh, wow, great.
In Bombay. It isn't Bombay anymore, right? It's Mumbai
Yeah,
right
it's
now.
Mumbai.
So,
Yeah.
So I was there for 5 years during my elementary school period. So like I'm very happy to see fellow Indian colleagues coming on board. Yeah. So
Yeah.
thanks for your introduction today. Any other questions from the audience? Okay. Silence means good in general, I guess.
Yeah.
All right. Then I will move on to the next agenda that we have planned for today. So it's there are some registry work group activities going on within OHDSI. There was a specific interest within the community, the APAC community, to hear about clinical registry efforts. So today I'm gonna replay a recording that was recently held in the OHDSI community calls on the clinical registry efforts in OHDSI. So the entire video is approximately 50 minutes. It's gonna be a bit long, so I will probably stop after the second presentation. So that will be approximately 20 minutes based on what I checked before. So yeah, let me go ahead and play. If you don't hear the sound, please stop me. I will stop sharing and share again.
Today, we're really going to be talking about the symbiotic relationship between clinical registries and OHDSI. And today, we have a great lineup of speakers, and we're only going to be presenting 2 registries, but we're really going to talk about how OHDSI can benefit the registries through EMR automation and through standardization, as well as how the registries can actually benefit OHDSI as a community as well. And so this is something I'm really excited about in this process, and I feel is an enormous opportunity. And so I'm going to state, and here I couldn't find a bigger font that fit the page, that OHDSI presents and the opportunity to lower the cost of clinical registries by orders of magnitude through standardization and EHR automation. And so what are we talking about? Clinical registries, there are hundreds of them where they collect data about patients about a particular disease, trying to study their outcomes. These are an important part of our biomedical discovery process. And we have many hundred throughout the US, and there are even more throughout the world. And the challenge is these clinical registries are still mostly living in the 1990s. And what do I mean by that is that the clinical registries almost have a high dependence upon humans and human ability to do chart abstraction on clinical data. So here was an analysis that was done, and I got this slide from John Duke, around it takes a half an FTE to collect data on 200 to 300 patients for a clinical registry. And so just think of the enormous cost it takes to collect data on patients around a disease, around having a type of a transplant, or receiving a medication. And so in comparison, I have roughly 2 FTEs for the 2.6 million patients that I have within our OMOP data set here at Johns Hopkins. And so really today is going to be discussing how do we take advantage of the OHDSI way, how do we learn from clinical registries, and how are we going to be able to help help manual registries move over into an automated fashion. And that's really what we're excited about talking about. I'm really grateful to Tina for reconvening the clinical registry working group, and I really encourage many people to join it, because if you look at this, for hundreds of registries, and these registries often have about at least 10 sites, so we're talking about thousands of site implementations of registries. We're really talking about tens of thousands of FTEs of people that are helping collect data for clinical registries. And this is a real burden on our health system. A lot of these people have to understand the context of the medical record. So some of them might be a nurse or a physician, and I really am on a quest to help lighten their load. We're seeing a lot of burnout from medical professionals right now, and this is what I would consider potentially non-value added tasks that we can take advantage of EHR data for. And so this has really been an exciting quest for mine. And what we've seen is preliminary studies have shown there's a lot of compatibility with the OMOP common data model. Its flexibility in semantics and in structure that we can be used pretty compliantly with CDISC or clinical trials as well, and is a fairly flexible data collection tool for clinical registries. And so there still needs to be more work to be done, but this is something that is a really exciting opportunity that we can really help disrupt or transform a field to really radically improve both the quantity of data being collected and the efficiency with which that data is being collected. And so one of the exciting things I wanted to share is we found a great partner in the FDA who shares our goals in trying to take advantage of this new field. How can we explore it? And so we've joined the CureID registry, which is around COVID-19, being led by the FDA in conjunction with the NIH, NCATS, and Critical Path. But the real exciting thing is they're, of course, looking for repurposing drug candidates to treat infectious disease. This started as a traditional registry where clinicians would enter case reports. And we got a lot of investment from the FDA and CureID to say, how can we take advantage of automated extraction data from EHR records? How can we invest in lowering the cost of the ETL process with the goal of even trying to be able to reach community hospitals? And so this has been a really exciting registry, and I'm really happy to report that registries can contribute back into OHDSI and help the whole field move forward. And in particular, we came up with 3 goals. And our real quest is making OMOP accessible to community hospitals that have got low technical resources, aren't able to deploy the OHDSI tool stack. And so this is where most care is being delivered in the US. And so we really want to make sure that they're accessible for clinical registries. So our goals were, one was to create a feasibility checklist for clinical registries to see how feasible it is to adopt the OMOP data model. The second one was actually, can we lower the cost to ETL EHR data into the OMOP format? I don't know if anyone here knows what the standard going rate is for OMOPing your EHR data, but if you talk to most consultants, it's usually around $150,000. And this is usually a burden that's really can't really well be justified by one registry. But when you start doing this as a standard for multiple registries, it can be really valuable. And then, can we also make it easier to deploy the OHDSI tool stack into a secure health system environment? So often when I start working with health systems, I find they've deployed OMOP and they've converted their data to OMOP for a registry like NIH All of Us or the N3C, and yet they're really not using they're not using Atlas, they're not using DQD, they're not getting what I consider some of the major value that they can get out of OHDSI because they're not able to deploy the tool stack. And so some of this was because of their enterprise security constraints. Some of this is tied to just not having the technical resources to do this. But our goals are, can we lower the barriers for ETL for OMOP, as well as lowering the burden on deploying the OHDSI tool stack into a secure health system? So that's really what we're going to be talking about today. Our first one was a feasibility checklist for clinical registries, and it is as you would think. So it starts off with how many of the data elements in the registry correspond to core OMOP concepts, and a lot of them typically do. They're looking for medications and labs and procedures, conditions and devices, visit types for inpatients versus outpatients, and so we found, in several that we've surveyed, that a good majority of the data elements are actually pretty much out of the box in the OHDSI data model, but generally not all of them. And then there will be things like there's some data elements that will need custom transformation scripts. A lot of data in an EHR is in a flow sheet or in a form somewhere, and that like vitals and smart data elements. And so custom scripts need to be developed to bring that data over. And then often with a registry, they might come up with custom concepts as well. And so we know the OMOP data model allows you to have custom concepts, but it requires coordination between multiple sites around a registry so that they're able to be consistent and figure out ways to have those questions added into a standardized lexicon. And then it gets a little bit more, it gets more exciting when it gets more involved when you say, what if they need to extend the OMOP data model to support the registry? And this could be like wanting to include imaging features or other types of aspects or relationships that are not typically in the OMOP data model. We didn't see this. We haven't seen too many registries needing to extend the registry to extend the OMOP data model. But this certainly requires a little more effort. And then lastly, we do see how many data elements really will require NLP of a chart review, An example will be symptoms at time of admission for COVID. And these things do require a natural language processing environment. And what I'm excited is today we're going to share our efforts with CureID and N3C, but I'm hoping that we can come back and continue this conversation and show where we're working with the CDC and the great team at Georgia Tech on deploying NLP to go after even more complex features and questions out of narrative notes. And so I think this is really the checklist you want to go through if you're a registry and say, why are we not using OMOP? And I really would like them to be asking that question, because if they can move to OMOP, they get so many advantages out of it. They reduce the cost of, they can able to then harness data directly from their sites. And so when the new registry comes to Hopkins, I push this at them saying, tell me why I can't use OMOP, because I've done all this work in mapping my data to OMOP, and I don't want to do an end mapping for every registry that comes out that wants to collect data. It's just too expensive for us. And so we found this is our first thing, that we just a simple guide for seeing whether we need what feasibility for mapping to the OMOP model. And I do feel I have met very few registries that actually go into needing an extension, or even some of them needing NLP. I think that's really where I think with the first three, we found a lot of registries can be captured in that. And that's really what we're going to talk about today. And so my first speaker is Matt Robinson, and Dr. Robinson is an infectious disease physician at JHU. He's been helping me lead these efforts. He serves as a faculty member in biomedical informatics, and he's been our clinical champion for our COVID-19 registry. And he's going to talk about our efforts to map this manual clinical registry into the OMOP data model. Matt.
Thank you, Paul. Normally when I speak to a group of clinicians, I'm trying to convince them why we should use OMOP. I don't have to convince this group of that. So I'm going to try to walk you through, the challenges of adapting this manual registry by focusing on just a single variable. But when you first approach this problem of adapting a manual registry to OMOP, as Paul mentioned, you've got to first evaluate the feasibility for each variable. How hard is it going to be to include it? As you approach this, you need to figure out what is the challenge versus the value added for each one of those variables that require extra effort. And to do that, you really need to consider the use case from the very beginning. And sometimes you need to identify alternative means of representing the data for these more complex variables rather than reaching in to extend the lexicon. And if there are difficult variables, if you want to do this in multiple sites, I think it's important to make sure you develop reproducible protocols so that it can be transformed similarly at each site. Next slide. So I'm going to focus on this variable, the WHO scale for COVID-19. It goes from 0 to 10 or 0 to 8, depending on how you look at it, going from the uninfected through the deceased. And it's a measure of how sick you are with COVID. Now, if you actually look for this variable, you won't find it as structured data in the EMR, and you don't usually find it documented clearly in notes. If you look here on the right, next slide, you'll see that grading ambulatory mild disease requires knowledge of whether a patient is symptomatic or not, which would require NLP. It also includes variables that are not usually included in an OMOP ETL. Click next slide. Such as respiratory support device. And when you dive further into that, you realize that some modes of respiratory support lack standard terms. Next slide. For example, non-invasive ventilation. I spent a lot of time poring over the SNOMED, and you won't find anything that accurately represents non-invasive ventilation. And another variable says such fraction of inspired oxygen, not typically present. Next slide. So as I mentioned, we need to consider from the beginning the use case. So we need to figure out, is this really important? So let's say you have a patient that has an oxygen saturation of 95%. You can just go next slide quickly. Receives drug X and survive. So you compare him to another patient who had an oxygen saturation of 95%. But then you realize that this patient died. So what's your conclusion? Drug X saves lives. Now let's look a little bit deeper. If we didn't have information on respiratory support device, you would think that patient A and B are appropriate to compare. But Patient A on the left is not that sick. Patient B is on a ventilator, but with supplemental oxygen, his oxygen is measured at 95%. So these erroneous conclusions can really make observational data not usable for its intended purpose. You can hit next slide a few times. So this WHO scale is really the inclusion criteria and endpoint for many COVID-19 trials. So we really do need this variable. You can go next slide a couple times. So we really do need this to make sure we're comparing patients of equal severity. And if we don't get this right, you can misinterpret the data and get erroneous conclusions like, hydroxychloroquine saves lives. Go next slide. So let's take another look at this, the feasibility. So we've identified that, there can be significant effort to use this variable, but let's go back to the use case and our needs. When we speak to the other clinicians and investigators, we realize that they really just want to use this for inpatient drug repurposing. So inpatients aren't graded by the presence or absence of symptoms. So if we focus on just 4 through 10, we drop the need for NLP. Then it looks like we actually really do need to get the respiratory support modality, and that's documented in flow sheets, which is a challenge. So let's go look at that next. So wading through the flow sheets is something that I think most informaticists try to avoid at all costs because it's ugly. They're highly customized to individual deployments. The context of the flow sheet entry matters, whether a patient's in the OR or if it's entered by a medical student or a nurse. What we found, though, is there is a way to protocolize this and make it reproducible. And so what we found is, first, we need to find the flow sheet entries that contain the data of interest. And so if we looked at just the names of the flow sheets, examples would be there on the right. They're not real ones, but you'll see that they'll vary so much between institutions, difficult. But if we have some idea of what values it may contain, that may allow us to find them more easily. So then you end up with a source to concept map that must be customized at each site, but with protocols, it can be made reproducible. So this is the journey that we've taken.
Great. Thank you so much, Matt.
Oh, sorry guys, I was speaking with my mic muted. So guys, that's the I'm gonna stop here because it's gonna move on to the a demo of a ETL tool. So before it moves on to that, it's pretty long. So if it's okay, I think it's better that we stop here. Is everybody here? Okay, there you go. Hi, Mui. Great to see a friendly face. So the rest of the video is available on the ㆍOHDSI community call website. There are some interesting demonstrations on a ETL tool used by the Johns Hopkins University, as well as a short presentation from Lee Evans on using a cloud environment for OMOP ETLing. So if there's no, I guess, a request from the audience, the community, to see the rest of the recording today, I think it's better we stop and we give back everybody the 19 minutes of the rest of the community call. Okay, I see Mui's in support of this. Is anybody else wanting to see the rest of the video, the recording today? If not, I think we'll just end the call for today. Okay, silence means good.
You can make everybody do it for homework, and then next week or 2 weeks from now, when we come back, we put a quiz out there and see how many people actually did the homework, right?
I'm not sure if I'm gonna do that. Be able to answer that quiz myself, Mui. But yeah, that's maybe I'll do that sometime as a surprise when we do the play the recordings, right? Yeah.
Yeah.
Yeah, I'll do that as a surprise. No,
Okay.
no telling before. I will definitely do that sometime. Yeah.
And this is recorded. Whoops, I wanted to say it wasn't my idea.
Oh, it's we even have your face on right now.
I
It
know,
was your
so-
idea.
Thank-
Yeah. Anyways, Swetha and the GVW team, thanks for being here with us today to introduce India. We look forward to any updates from your side of the region. So yeah, thanks everybody for being in the community call today. Mui, do you have any last comments, or I'm gonna end?
Remember to go register for the APAC symposium. Don't forget
Yeah.
that.
Yeah,
Okay.
I will post this on the Odyssey website so that you see Mui emphasizing on the registration over and over again. All right, guys. Thanks for your time today. We'll see you in 2 weeks. Bye, guys.
Bye.
See ya.
See you.
Bye. See you.